Hello, everyone. Welcome to Personal Insights, Unpacking the Power of Psychiatric Advanced Directives. My name is Valerie Cordero, and I am Co-Executive Director of Families for Depression Awareness. So glad to have everyone here with us as we begin our panel discussion. Going to go to the next slide. Yes. So our agenda for our discussion is we are going to introduce the panel that's going to be joining us. And then we're going to go through a series of questions about psychiatric advanced directives. We encourage you to go ahead and put some questions or comments in the chat. I believe we're having some trouble streaming to Facebook. So we're going to see if we can resolve that for everyone who is trying to watch us on Facebook. And we're going to just keep on rolling. It will get there eventually. And if all else fails, we will post the recording from our discussion to Facebook at a later date. But we will have a question and answer period. Feel free to submit your questions and we will pose them to the panelists. We also have some questions left over from a webinar that we did with the Copeland Center on psychiatric advanced directives. So if we don't get any questions from the audience, we will be pulling questions from there. Finally, we will remind you that we are doing a survey to evaluate our program. And so if you can stick around after our presentation, please do fill out the survey so we can always improve our programs in the future. I would love to tell you a little bit about Families for Depression Awareness. Our mission is to help families recognize and cope with depression and bipolar disorder to get people well and prevent suicides. Our philosophy is that when a person is living with depression or bipolar disorder, it's the people around them. It's the parents, the siblings, the grandparents, the friends, all of those people in their life that really have a strong and powerful position to support that loved one, yet they don't always know what to do. And so that's where Families for Depression Awareness comes in. We provide education, training, and support specifically geared towards family caregivers so that they can be a strong advocate for their loved ones, they can be a partner in care, and most importantly, so that we can preserve family units, because that's what we really believe helps to improve health outcomes. The hub of our resources is our website, familyaware.org. Some of you may have already visited it, but if you had not yet had the chance, please go to familyaware.org. You will see other webinars and workshops that we have had in the past and ones that are coming up in the future. We encourage you to use our web tools, such as our depression and bipolar screening test, our caregiver stress test. We also have a mental health family tree tool on our website. And you can find just loads of other resources, including family stories and expert interviews. So we encourage you to visit familyaware.org for more information and resources for family caregivers. Before we launch into our program, we definitely want to thank our funders that make our programming possible: Takeda Lundbeck Alliance, Johnson & Johnson Innovative Medicine, Massachusetts Department of Public Health Suicide Prevention Program, our corporate members, Sage Therapeutics and Biogen, Takeda, Johnson & Johnson Innovative Medicine, Alkermes, and then, of course, people just like you. People just like you are giving us money. They donate to us. They believe in our mission, believe in our cause. And if you are one of those people who have given us a financial contribution so that we can provide programming for free on issues of depression and bipolar disorder and how they affect families, we thank you. We appreciate you. It is now my honor to introduce the panelists that are going to be joining me for our discussion. We have Matthew, Amy, and Natalie. So I would like to read a little bit about their bios now. Matthew Federici is Chief Executive Officer of the Copeland Center for Wellness and Recovery. Matthew came to the Copeland Center in 2010 and is an internationally recognized speaker, trainer, and consultant on recovery, wellness, community inclusion, and peer support. Matthew's personal and professional journey in wellness and recovery includes involvement as a family member and a mental health peer support advocate for over 20 years. Welcome, Matthew.
Thanks, Valerie.
Next, we have Amy Detmer. Amy has had over a decade of experience as a peer support specialist, and she also worked at the Copeland Center for about 8 years. She has experience in youth serving systems as she was institutionalized in a residential treatment and diagnostic center as a teenager. Turning her experiences into meaning, she graduated from peer specialist certification training in Pennsylvania when she was 21 years old. Since certification, Amy has worked as a certified peer support specialist in community based settings, residential settings, and as a peer support supervisor. Welcome, Amy. Finally, we have Natalie, which I turned too many pages. Here we go. Natalie Klaus Rogers was hired to work on a peer-run warm line in Cincinnati, Ohio, over 15 years ago. Today, she continues her journey in peer support at Mental Health America in Delaware. She was a peer educator in the community for 6 years and is currently the manager of education for the Department of Corrections. She is a certified supervisor of peer specialists, advanced level RAP facilitator, certified mental health first aid instructor, and incoming member of the Delaware State Rehabilitation Advisory Council. Welcome, Natalie. So we're going to start our questions, and Natalie, we're actually going to begin with you. What prompted you to create your own psychiatric advance directive?
First of all, shout out to all you caregivers and supporters. You rock. I am soon to be a 49-year-old mother of an 8 and 9-year-old. But when I was in my 20s, I had ECT or shock treatments, which is a perfectly fine procedure that 100,000 Americans receive each year. But in my case, it resulted in permanent memory loss. If I met you within the year of my treatments, I wouldn't remember you. So we could have been on a date and I wouldn't know you. I had to transfer colleges closer to home. And when I originally started college, I took a test and I tested out of all the math I needed to get my BA. But when I went to take the placement test again at the new college, I couldn't recognize the greater than and less than sign. I kept thinking about alligators, because remember in school, they would say the big alligator eats the higher number. But I couldn't remember what. In the state I was in, one of my family members had to sign for for me to get the treatments. And it was a very hard time and a very, very rough recovery. And this Tuesday at my house was Taco Tuesday. Tomorrow is macaroni and cheese. Friday is always macaroni and cheese with broccoli. There's no homework on Friday. And I want to remember all these little things, let alone everything that has happened with my babies in the past year, Halloween costumes, homework, everything. So I would like, if I don't have a voice, for someone else to have a voice for me, and maybe for certain procedures, certain medications, certain things, certain hospitals to not be the best choice for me, for someone else to have that voice when I don't have that voice, if that makes sense.
It does make sense. Maybe I think we're getting a little bit of feedback. So I would like to actually give it to Amy for a second, because I think we can't assume that people have access to all of our other resources and actually know what a psychiatric advance directive is. So let me just back up a bit. Can you tell me what a psychiatric advance directive is and give us some background on that?
Sure. Well, I'll also start with Natalie's thank you, caregivers, for loving on your loved ones, and for Families for Depression Awareness, of just really creating this atmosphere of, we can go through these things together with our loved ones and with the supporters that we have in our lives. Great question about what are psychiatric advance directives overall, and really what they come down to being as a nationally recognized rights protection document, that if we wind up being in a hospital setting where we are deemed incapacitated or incompetent, meaning a doctor saying that we are not able to make decisions on our own behalf due to our mental health issues and concerns, that this psychiatric advance directive is something that we pre-write, pre-think about, and have our wishes outlined so that the doctors and the medical system can see, this is what we believe works for us. This is what we believe we want for our treatment and for our care. And it gives us an opportunity to have an outlet for describing that, for having our supporters and our loved ones being a designated advocate on our behalf should this come in. And as I said, serves as a legal protection and a legal force. Any service providing organization, hospital around the country that receives Medicaid dollars is mandated under federal law to actually follow this. So it really is something that is a document to support us and to support our rights and to support the type of treatment that we want. And I don't know, Valerie, if I'm allowed to do this, but I want to invite Matthew to also speak on this. I've been doing psychiatric advanced directive work with Matthew for a number of years now. And Matthew is really one of the biggest experts on psychiatric advanced directives from a peer voice and peer perspective that I know. So Matthew, I'm just going to invite you in.
Matthew, please. I'm going to have you unmute yourself, Matthew, real quick.
Yeah, no, Amy, I think you described it quite well. It might be important for people to recognize that in some areas it's referred to as the mental health advanced directive versus psychiatric advanced directive. And I don't know if we touched on that, there's some couple basic elements, which is an element where you can make your own declarations in writing versus an agent based, where you designate a decision maker. And I think as Natalie referred to, is like a more of a combined, where you put your preferences and an agent, and you can kind of specify in different areas. And different states allow for different things. I'm a big advocate and proponent that psychiatric decisions, mental health treatment decisions should be inclusive of all health decisions. And that this is really a patient's rights issue, that for all of us, that there can be moments for various different reasons that decisions have to be made and we can't be consulted in that moment. And that we all need to have these advanced directives and inputs in place, not only to kind of benefit ourselves, but also to be a better supporter to the professionals treating us that maybe don't have the information they need, but also the people who care and love on us. I know firsthand what it's like. I was actually in a provider position where the family thought I knew the person best. I had established a really good, close relationship with them, and turned to me for some while the person was dealing with some cardiac issues. And the family turned to me for what would this person want. And that was a real wake up call for me, that whenever we're in a caretaking role, we need to have those discussions, because it happened to be in an area I knew what their preferences were around a lot of mental health issues. But in this case, I wasn't sure. And the family turned to me, and I wanted to be there just as much for the family as I was for the individual. So I think the benefits of looking at this holistically are going to be important.
Agreed. And I would also position from the caregiver perspective, and we're going to get more into that as we continue our discussion. When your loved one has a psychiatric advanced directive in place and needs it to be followed, and you're the one there with the providers, it gives you a sense of confidence. It gives you a sense of assuredness that you have your loved one's wishes and their preferences and their desires on a piece of paper, legal, and you have the backing to say, no, I know my loved one, I know my sister, I know my cousin or my father has tried that medication before and it doesn't work for him. And he says that if he's in a manic state, these are the medications that have worked the best for him in the past, or whatever the situation is. It's really a gift to the family members as well to be able to enact those wishes with confidence, and also avoid any disagreements in a family. Well, Susie would have wanted this. No, Susie would have wanted that. Well, she wrote down exactly what she wanted, and it's legally binding. So let's try to follow it as much as possible. Amy, we're going to come back to you. How did you decide who would make decisions on your behalf when you're unable to? And can you tell us a little bit about those conversations when you decided who that would be?
Yeah, more really great questions, Valerie. I also just want to kind of second what you said about psychiatric advanced directives are really also a gift to our loved ones. They're a gift to the medical system in the sense that what that means for me is it means my parents, my family members, my supporters, they no longer have to play this guessing game of what do they think is best for me. And the medical system has some information already about what do I know works for me. So I just really echo that point that you made. And it was a big shift because I used to think that psychiatric advanced directives are really for me and just protecting me because of the bad experiences that I've had. And I've now been able to really see that this is as much for me as it is for my loved ones and my supporters in my life. What I want to say to this question of like, how have I chosen who's involved in my psychiatric advanced directive and what does that look like? It's been a challenge. And I'm going to speak to something that Matthew started to bring up is that there's different types of psychiatric advanced directives. So some of those are very instructional where I can just have my wishes written down. And others are where I have a power of attorney, which would be the supporter that I designate or a designated agent. And I've really struggled with this decision a bit in my life. Many of my supporters for a number of years, the closest supporters that I would have trusted in this role, were kind of all over the United States. I was doing national work for a long time. The people that I know who know the system, who know, kind of share the same beliefs that I have around whether I want or I don't want psychiatric medication. A lot of those people are scattered. So it made it really hard for me to make a decision on who's actually going to be this person that I designate legally as an advocate and as that supporter in this way. So I've actually settled on not having that supporter in my life at this moment. And I share this with, that's not the intention that I want long-term, but that's where I'm at right now. So right now I have this instructional psychiatric advanced directive with the goal that when I identify the person that I trust that's going to speak in a way that I trust on my behalf, is going to really hear what my wishes are from my perspective and take the time to hear that from me. And also somebody that's going to be like good at maybe questioning the decisions of doctors at times. A lot of the reason I want a psychiatric advanced directive is because of having poor experiences in the past. And that's the driving factor for me. So I think that, that is okay. And I've had to come to terms with it being okay that I don't have that designated person right now. With that being said, I do want to say one of the resources that Valerie talked about was a crisis planning webinar that we were involved with a few weeks ago. And what that really means for me is like, that's the first step to completing a psychiatric advanced directive, is taking the time to understand what does crisis look like? Where do I want to go? How do I kind of get the support I need maybe before I become to a place where I'm deemed incompetent or incapacitated? So that's where my family really comes in, where my supporters come in, is in that crisis planning stage where they know about peer respites that I can go to kind of be a support before I need that hospital setting. So those conversations have gone well. My family does know where my psychiatric advanced directive instructional pad is located. So they kind of play the role of making sure that that document goes with me if I need to go somewhere, making sure the medical professionals have that if I need it, but they're not actually designated on my plan itself. Yeah, and I guess the only other thing that I have to say here, just looking at my notes real quickly, is that in doing psychiatric advanced directive work and thinking very deeply about my own situation and my own supporters, one of the things that we'll often talk about in peer-led psychiatric advanced directive groups, where a lot of us are coming together and we're talking about developing and working on our pads, is this idea that when we're choosing supporters, we're choosing somebody that really lives by what we call the platinum rule, which is doing onto others as they'd want done onto them, which I was raised different than that. I was raised do unto others as I'd want done onto me. And this is really about shifting that to take the time to get to know, what is it that my loved one wants? What is it that my supporter wants? And that's the kind of supporter that I really want to choose, that's going to go from what do I want rather than what do they want for me.
Well, we're getting a lot of thank yous for your comments here, helping you think about how you would want to structure your pad. So that's great. And Kay mentioning that her mom is hers and is a registered nurse and can really be an advocate. Thank you, Kaylee. That's helpful. Opening up the floor for other thoughts on this question about how do you choose the right person to be your designated person in your, either as your power of attorney or otherwise supposed to enact your pad.
I hope that I have made my wishes or my instructions written and very clear, but my supporter is no one in my immediate family or household. It's someone who loves me and knows me, but is a little bit removed. So when it comes time for those hard decisions, I don't want my husband, who will be emotional at that time, to be the one in that position. So it's someone I've talked to, someone I know, love, and trust, but maybe be a little more removed when it comes time to make those hard decisions.
That certainly makes a lot of sense, because the people who are closest to you are not always the best decision makers in those heightened emotional situations. And we know our families, and we know who would be good in that role and who maybe should just be in charge of getting everybody coffee. So just want to remind folks that we have a Psychiatric Advanced Directive fact sheet that you can download. The link to that is in the chat, so feel free to do that. It has a lot of helpful information on it. Anything else anyone wants to add on this question before we move on?
I think it can be very hard to reconcile that. For a lot of us, there are people that we specifically do not want involved. We do not want to visit us. We do not. And sometimes we love those individuals, but in that situation, don't want them around. And so this can be a really important element to have specified. But perhaps if we, have a long range relationship with the person, it means having a very tough conversation so that while we're in that crisis, we don't have another crisis, and our supporters don't have a crisis of somebody showing up whom we don't want there. And but definitely have seen in my case, it's a situation of having the discussion about who's in charge. I have two loving people in my life. One has more of a right of way to my healthcare decisions because I impact their life as their partner. The other, having a son myself, I understand, would want to jump in and have a lot to say, but come at it from a very different viewpoint than my partner. And so I personally experienced in a healthcare crisis where it made things worse for me because one party didn't really respect the boundaries of the other person being the main decision maker for me. So I think when you're thinking about this, that's a critical piece. Is really thinking through that, as well as, it's really important you may have somebody who is a great person who really gets you, you really trust them, but are they going to be available when you need them? And so that could be another element. What's their geographic distance to you? What's their life look like? I mean, do they have 10 kids and a really high responsible job, and are they really going to be able to drop everything at 3 a.m. and be there in the capacity you need them to be there? So these are all really tough decisions.
They are tough decisions, and I think something that we covered pretty thoroughly in the webinar on this topic was that you want to make these decisions when you are in a well place, and the time of crisis is not the time to be making those decisions, because number one, if you're the person with the lived experience of a mood disorder, you may not be in the best place to make that decision yourself. And again, everyone else's emotions can be heightened. And so you may not remember, oh, I want to be sure that they don't do this, or this person is there or isn't there. So planning is a big part of psychiatric advanced directives. And I believe someone else mentioned, sitting people down and having honest conversations about their role and what you would want, and making sure everybody understands. And again, all of those questions are answered and those issues are resolved before a crisis happens. Hopefully, we never want a crisis to happen, but if you have those conversations before, then you're having it in a place where the emotions maybe aren't so high, and people can hear what you have to say and understand why you made the decisions that you made. Not that you owe anybody an explanation, but it certainly helps to get everybody on the same page. We have a question here. How easy is it to substitute a new person to be your agent?
I can jump in response to this. Great question. And this is something that comes up a lot, is like, can we change our psychiatric advanced directive? And you certainly can. As Matthew was saying, kind of even the terminology of psychiatric advanced directives can be different from state to state. So it's hard to give a clear answer to this, because the process may be very different all over the place. There's a really great resource called the National Resource Center on Psychiatric Advanced Directives, and you can go there and see a whole directory of what that process looks like, what the forms look like, what do you need to do to get it official, legalized. Where I am in Vermont, it would be a pretty simple process. I would contact Disability Rights Vermont, that they house a full form, and if I need something updated, I just go to them and fill out my information, and they can very easily do that. But not all states have that kind of standard, simple type of process.
Mm-hmm. Yeah, if I can, I think that I'm not a lawyer, and I just want to make that statement. But I do know that I've had to know the law and advocate for myself and for people who I care about. And I do know that there, a couple tiered way I look at this is, if I don't have something in writing, I have a very poor basis of advocating for myself. If I have something in writing that is witnessed and trusted people who are going to stand by, what I said, I have even a greater. If I have something in writing and I have witnesses and supporters, and I have a law behind it, I have a lot of weight. And none of these situations are ever a guarantee that, when you're in a medical situation, that the medical profession waives its rights to make what they feel is the best decision they can professionally, based on what is considered to be common best practice in science at the time. However, we can make some really strong cases. We can have advocates involved, and we can have contingencies. And with a really good lawyer, I know that my advanced directive plans are financial, whole medical health, and psychiatric decisions, and living wills and trust for my kids is all wrapped up in one, with legal advisement. And I have contingency plans. Should something happen, my partner has certain rights. Should something happen to both of us, we have somebody else appointed. And so best case scenario is that you do have alternates, alternate agents is designated, and and regardless of the nuances of the law or not, if you have witnesses and legal weight, and you're presumed to be competent, and you state all this information, you have active people being involved in forming it, it's very difficult for a medical professional to say, we made this decision despite all of that. And so I just really would advocate that this is a work in progress for all of us in our lives, to really think about and to do, not just for this person or that person. And again, I think you can have substitutes or alternates in your plan, and I think it's very advisable to do that. So, however, with that said, that can be really overwhelming. So just start where you're at, I think, is really important. Like, if the very least you designate one person who might be available, that's better than not having anything in writing, not having talked to and thought about a trusted person to be involved. And I would always say, coach your agent to show up in as professional attire as possible. Carry a notebook and write down every name they come across. That will get you a long way. I've done that for friends of mine where I wasn't even legally designated as their agent. And I found that the medical professionals stood very much to attention. And there was not necessarily any mood disorder or psychiatric issue. It was just, there was a medical situation, which can be very overwhelming. They were in an ER and not in a good place to be making decisions, and asked me to show up and support them. So anytime we're in any of that situation, a lot of us are challenged to be making the best decisions and really thinking about who our agents are going to be. I just can't emphasize it enough.
Yeah, and for folks not to be intimidated by I don't know why this is doing this. Not to be intimidated by the that white coat syndrome, right? If you have if you know you have the authority given by your loved one, and you know that that these are their wishes, as you said, you know, dress the part, get the notebook, write it down. I really advise that to anyone, for anyone who's going in for a medical procedure, to write everything down. For medical billing purposes alone, but these are also certainly great reasons to do so. Amy had mentioned a resource before, so we put that in the chat as well. The National Resource Center on Psychiatric Advanced Directives. The URL is there, nrc-pad.org. Great resource if you're looking for information particular to your state, and lots of other resources on psychiatric advanced directives. Natalie, can I just ask you, how did it go, or have you ever talked to a medical provider about your psychiatric advanced directive? And if so, how did that go? And did they know about what a psychiatric advanced directive even was? And just what was that like?
It went really well because I have medical providers in my psychiatric advanced directive. Because should I end up in a psych ward, you're really not familiar with that medical provider. They don't know you as well as other medical providers. So I have in my directive that before certain procedures or certain things would happen, that I want them to consult certain medical providers that know me and my health better. So I asked those medical providers, would they be willing to be in my directive? And they readily agreed.
That's encouraging. I hope that happens for everyone. On that same note, since we're talking about providers, Matthew, are PADs well known in the provider community? Have they been educated by any kind of process to know to bring it up with people with lived experience who are looking for more agency in their care? Can you address this question for us?
Yeah, I mean, I love this question, and any questions about, you know, particularly implementing this more systemically. And I think just real quick, they're not well known. They're you know, not well known enough. My experience, my experience in this, in over 20 years working within provider roles myself and in agencies. Bolstering support of other professionals, trying to, you know, move it forward where more people have the rights. And I, you know, began this work before in my state of Pennsylvania, there was a law specific to psychiatric advanced directives under the basis that I was sharing earlier, that it's just good practice, that anytime people are documenting and stating what their wishes are while they're presumed to have sound in mind, which we are, unless somebody's telling us otherwise, you know, medically saying you're not of sound in mind, you know, we're presumed to have that competence, and getting advocates and the wishes down it's beneficial for everybody, and it's a basic patient bill of right, you know. So having worked with that and then having the law over 20 years, I'd still say the majority do not. There is a real strong aversion to it within the provider community because of it's a very liability driven environment. Mental health is not like diabetes and insulin or an allergy and an EpiPen. Most of the interventions we have it is not like that, very clear cut, where it's, you know, pretty undebatable, in some of those situations, what a person may need. In mental health, as they say, the heterogeneity of the conditions and the lack of validity and reliability between diagnosis and the path of treatment is pretty scientifically established. There is no validity or reliability to that. So it's a very individualized approach for everyone else. Most of the things that are going to support people are going to be psychosocial related. And so this notion that, mental health is a lot like other medical conditions, where if you have this, you get this medication, is just not the case. In particular, the beliefs that that mental health or mental illness is a chronic and long-term condition is also an unfounded belief. It really scientifically, it's episodic. We don't know how many episodes a person's going to have. If they're going to have more than one episode, how long it will be, there's no predictor to that. But this notion that mental illness is this clear-cut line from diagnosis to medical treatment, and that it's a chronic and long-term condition, both of these are just factually not the case. But these beliefs get very much in the way of the provider fears of liability when it's being handed over to the individual to make decisions about what they want and what they don't want. Having rolled this out along with other colleagues as an agency policy to offer and support people the opportunity to know about this and to do this like we're doing here in this format, I can say I came up against the realities of discriminatory and consequentially internalized stigma. So the belief that we are not capable and competent or to be trusted about what works and doesn't work for us is very pervasive. And often we internalize that in those services. Lots of people are telling us what to do, providing direction to us, questioning the life decisions we want to make. And sometimes it can be internalized as why I have, my emotions are too all over the place and I can not make it. Meanwhile, in none of these cases are we legally deemed incapable of making decisions. We're treated as such and viewed as such, and it's a barrier to overcome. One of the ways in which we're trying to overcome this, the Copeland Center is providing a peer-facilitated group experience where people can explore the kinds of questions and things that we ourselves need to answer for ourselves before we begin putting these documents together. One of the strong recommendations is that electronic health records just begin to include, does the person have one, yes or no? By and large, the system and the provider networks need to learn the language of this. And we, we'll have to do our own advocacy to fight for, no, we do know what we need and want. And we have the right to state that up front. I think one of the cases that I have seen in that process is related to this question you asked, Valerie, about how do we decide who to put in support us in the advanced directive. Many people, due to institutionalization and a lack of understanding of the role of community inclusion as important in our mental health recovery, have lost or not have had the equity to develop relationships with people where we can have good agents, trustworthy good agents, because healthcare professionals or people involved in our treatment cannot be agents. It's a conflict of interest. So they have to be people who are outside of our current treatment circle. And for a lot of people who've experienced extreme institutionalization and a lack of self-determination because they're in programs all the time, surrounded by professionals all the time, it comes up where I don't have any supporters to designate as an agent. And I've seen systems that are concerned about the liability of handing decisions, making it over, go, well, they don't have anybody they can choose, right? And this is where we need to be very proactive to say, this is a rights issue. Rights are intimately connected to health and well-being. And as a professional, we need to, if we see that that's the case, we need to identify what we can do to help support that person to develop relationships in the community like everyone else, where they have friends and family that are involved and listened to in their care. So, I get really excited about this question, like when it comes to providers' receptivity to this. I mean, I think more than having to overcome their fears and concerns about this, we need a system of providers that are excited about it, see the opportunity. Like one of my stories is, you may be called upon to make a decision in an emergency by family members who love this person. And like I was, where I wished I was equipped with that conversation with that person to say, well, we didn't get it in writing, but I know that, what Bob would have wanted, this is what he told me. And I could have handed that information to the family member and they could have made the decision. So we're going to be asked to make the decisions anyway. Wouldn't it be nice to actually know what the input of the person was?
I want to tease out a couple of things from what you just said, because you gave us a lot of great nuggets there. One is that because people with a lived experience, if they have had a lot of experiences in hospitals with hospitalizations, with residential programs, with systems, they might not have had the opportunity or have been unwell for long enough where they have not had strong interpersonal connections with family and friends and community. And the two things I heard you say out of that I just want to make sure people got was, number one, if that is the case, that does not mean they don't have the right to still determine their health treatment and what happens to their bodies and their minds. And number two, the action step, if that's the case, is to connect them with ways of building community. A peer support movement is definitely a big one that I would think of automatically, but finding ways to help them build that protective factor of good, strong interpersonal connections with family or friends or community, religious group, social group, ethnic group, cultural group, whatever, so that is not the case for their whole lives, because it doesn't have to be, and it affects so many other parts of their lives. The other part I wanted to tease out is, and this is where I get what we tell caregivers a lot in Families for Depression Awareness. If you have information that the primary care provider, who is the person that your loved one is comfortable with, and that's who they're going to see, and that's the only one they're going to talk to, if you have information that would help them help your loved one, you bring it to them. You can say, I've heard of this thing called a psychiatric advance directive. I know you're the only person who write prescriptions for my loved one, but can we work on this together? Can you give us other resources where we can send my loved one to work with a peer support specialist or work with someone else to develop this, or just give us any kind of extra referrals? Because sometimes you as the caregiver, you as a person with lived experience, may have information that you have to push your providers to use or to consider, or to have more available to you. And it shouldn't be like that. But if that is the case, you have to, again, kind of stand in the information that you have and say, look, we want to work on this. This is what we think is going to be a good step for our loved one, and get on board, kind of. So I just want to pull out another question here. How can I encourage my loved one to write a PAD without seeming controlling or overstepping boundaries? I think this is a great example of where caregivers can get stuck sometimes in not knowing what their role is and not knowing how to navigate that relationship, and wanting to stay away from taking over, but saying, we can't go through this again. This was a horrible experience of what just happened, or even I heard about this thing and I think it could be helpful. So maybe what are some talking points? What are some conversation starters that people can use in discussing a psychiatric advance directive with a loved one?
Well, Valerie, I'd love to jump in here with any. What I love about psychiatric advance directives and conversations around it is that any barriers that come up that people might place, or, if providers present for barriers, well, what if, and what this, any of the things that come up when thinking about this for me immediately points to an opportunity. Oh, that's the opportunity that we need to focus on here, right? If it, as we just discussed, is it, well, there's no supporters that the person could have as an agent. Oh, that's the opportunity. That perhaps is the path to rehabilitation, recovery, and support. Is let's work on that, right? So I think particularly when it comes to the questions that arise with psychiatric advanced directives, it immediately points us to what's needed, and sometimes what's needed in the relationship, right? And so it's a great opportunity, right, to point out, oh, well, this is a boundary issue about their life and my life, and how do we have that conversation about my needs and their needs, and how those needs are intertwined with each other, I think that's, the question is my loved one. And I think when I think about my daughter, and I think about my partner, and I think about my best friend, they're all loved ones, but the context of those relationships are really important in terms of how I would go about this. I think, the first thing is just really when's the right opportunity to broach the subject, right? I think, again, broaching the subject from the vantage point of mutuality is always helpful. And that's where I would strongly encourage all of us to think about, are all of our healthcare decisions, including psychiatric. I think if we're starting from a place that psychiatric and mental health treatment questions aren't relevant to us, we're starting off in the wrong place. Mental health is a spectrum. And at any point in time, we may find ourselves intersecting with a medical system that is going to propose psychiatric treatment in response, perhaps, to situational stress or other factors. This is a growing concern. I experienced this with a loved one where we went into the emergency room. We weren't sure what was going on. Thankfully, I have the experience and background I have, because the line of questioning was leading my loved one towards anti-anxiety medications, when in actuality, they were having a stroke. So I see the opportunity for any of us to be presented with, questions, perhaps at a time when we're not in the best to make the decision. So, I think having the conversation from a vantage point of what are some treatments and preferences that we would all want or not want in these situations can be a great starting point. But also, I don't know the situation here, but I know I can imagine in a situation of my own where, I've gone through with a loved one multiple hospitalizations and situations where, the conversation can start with, as we've gone through these situations, things have happened that you clearly did not like and did not want. I have been taking notes on these things so that if we find ourselves in that situation again, I can be a better supporter to you. Would you like to take a look at some of what I've been learning? And I think that's the important place to start with before we get into, let's make this a legal document that'll be an advanced directive, and to really start from a place of, wanting to support that person to have increased voice and choice. If we start from a place of our preferences for that person in that situation, it may not be the best conversation starter.
I love you and I want to help you. So I need to know what you want. And I want to hear your voice even when you cannot use your voice. So please help me help you.
That was masterful. Hopefully everybody was listening to that. Amy, anything to add to bringing up this conversation and respecting boundaries with your loved one, or maybe something that you've heard or seen that would be helpful to others?
Yeah, I think this is a really great question. And I think something that a lot of family members, those of us supporting others, deal with sometimes. I really love what Matthew said about how do we create more mutuality, and that this is the kind of thing that isn't just for that loved one. It really could be for us too. So I think approaching of, hey, might you want to try something with me, and it not being solely about that loved one that we're trying to support, but being about us too. And I think that creates that environment of mutuality. I would also say, I try to be very conscientious about how I say things. And I don't know if anybody's ever kind of heard this saying of like, don't should on me, where like those shoulds come out. You should do this, you should do that. That never works for me. If somebody's coming at me with that kind of thing, it's an immediate, I don't want anything to do with what you're telling me I should or should not do. But if you present something with, hey, I learned about this thing, it might be something that you'd be interested in learning about. And then like tying in Natalie's masterful words, this is about keeping, our wishes at the forefront. Your wishes at the forefront kind of thing. You said that way better than I could, Natalie, but that's what comes to mind. And then also, I think this idea of just being able to acknowledge and honor the resistance of our loved ones. Resistance is something that can be like thrown out there as this like negative thing, but really it's something that, many of us have recognized or have learned is like, that's our strength, is being able, and where our power is being able to say, yes, I'll do this, or no, I won't do that. And I think that being open to the resistance that our loved ones may come with is okay. They are allowed to have that. And it's seeing that as a positive thing. And at the same time, making sure that there's resources and available for when maybe we want to let some of that resistance down a little bit, that we can learn on our own. I just worked on a really great document. The Copeland Center Youth Move National did it, and it was around psychiatric advanced directives for youth and young adults. An incredibly resistant, sometimes proudly resistant age group. And this is all about just these first things that maybe we want to think about. This idea that like, yes, there's voice and choice in these things, and really trying to come from that like mutual perspective of how these things support us. And sometimes providing documents like that or information like that is also a lot more understandable and readable than like, oh, here's this like lengthy jargon legal form to fill out. That's one of the reasons why it took me a very long time to complete a PAD, because these lengthy legal forms, and I think is also one of the reasons to the prior question around what are some of the like hesitations of the system and providers doing more of this. There's not that much knowledge out there beyond these forms and documentation. And sometimes when we don't know things, we do nothing. Because we don't know how to speak to it. So the more information and resources that can be provided to our loved ones, I think is also something that could be beneficial.
Absolutely.
We're talking about a relationship here, so it's very easy to kind of say, here's the script, and so really just trying to think about that relationship where you can, talk to a loved one about this. I think it could be beneficial to think about how much is choice and voice a part of the relationship, and mutuality a part of the relationship, around a lot of other things before. If you're just coming in at it on this, it seems like you're picking on this tough time kind of thing. But really building a relationship where it's not about controlling the outcome. It's about empowering the relationship, where we get to support each other and inform each other around what's working and what's not working. And there can be like little micro opportunities to start saying, oh, what is your preference for this if we do X, Y, and Z? And then it becomes a more natural part of the conversation, like, oh, we've been talking a lot about what our preferences are for supporting each other. There's this big thing in our lives where this has happened, and I don't know what you would want in this case. And but again, so I think if this is the first time you're approaching the relationship in that way, it can feel very different.
Thank you. So I'd like to go to Natalie with this question. We only have time for maybe this one and one other. So Natalie, in the process of creating your PADs, was it triggering because you have to go through many different scenarios of what could happen, or maybe what has also happened in the past? Was that a hard process to go through? And if so, how did you get through those tough conversations and the places that you had to let your mind go to in order to create your PAD, your psychiatric advance directive?
I started way back when with a template. and I had to take breaks, and that's when the magic of peer support comes in. And it also helps to talk about other people and what their choices are and what they choose to do, and to, use other people as a sounding board. But it's not easy. It's hard, but if you do it when you're in a good place, I sleep better because I have the peace of mind knowing that my voice will be heard and my choices will be known. So it's worth the stress to go through that. Definitely.
Thank you for that tip. And I think, as you said, you do it, you take breaks, the peer support makes a difference. And I think also seeing that, seeing the benefit that will come from going through all of that is a good way of getting through. I'm going to ask everybody this final question, and then we will talk about our follow-up survey and how folks can give us their feedback on our discussion. What advice do you have for caregivers who want to support their loved one's treatment during a mental health crisis? Why don't we stay with you, Natalie, and then we'll ask Amy and then Matthew.
I think holding space and just being there, the fact that you care and that you're willing to be there, says a lot.
Amy, what advice would you give to caregivers who want to know how to best support their loved one during a mental health crisis?
Yeah, I think this is very similar to kind of the discussion we were just having. But I think the biggest thing is, for me, get us connected to other people that maybe it's a little easier to talk through some of this with, in a peer support type of environment where people have maybe had similar experiences. As Natalie said, like, yeah, this can be a triggering process. And I know for me, it was very helpful to be with like minds, with people who had similar experiences, to talk that through as I'm going through that could really just understand from that perspective. So yeah, keep finding us ways to be connected to the peer community.
Thank you, Amy. Matthew, final words.
Oxygen mask. Don't forget that you're as good of a supporter as you are well yourself, and know your tools, your own supporters. When someone we care deeply about is going through a mental health crisis, we're going through a mental health crisis. I think I said on the last webinar, I didn't learn until later, I think I remember being like out in a canoe or something with my dad, and he shared, when you went through that, I didn't eat or sleep for 3 days. And he's like, and I'm just realizing that I was going through a major depressive episode. Thankfully, my supporters had each other. And so that's how they got through that. I would say, again, voice and choice. There's a lot of unknowns about the path and the course of each person's recovery. It's not this, do this, and this, and then you'll be fine. A lot of it is unknown. A lot of it depends upon the person being empowered to figure it out too. And so any time where we're shutting that person's voice and choice out is not good. And anytime we're finding opportunity for that person, despite how hard things are, to still have voice and choice. I was very fortunate. I didn't need a psychiatric advance directive, but at the most pressing of times for me, I knew that I was heading towards a hospitalization, but I was still engaged to interview and pick the hospital. And I was very privileged to have that. Not only the opportunity to choose which setting I was going to, but to have supporters who are willing to stand by and say, this is what's going to happen, but we want you to still have input. And I feel very fortunate that despite that, there was a lot of reasons for my supporter to say, you're done. You have no input on this at this point. But they still maintain it, any opportunities that they could, that, to give me the dignity of having a voice.
We are so appreciative of Matthew, Amy, and Natalie for sharing your personal stories, your professional expertise, and all of your thoughts around psychiatric advance directives with us. Thank you, everyone who has watched or will watch this on a recording. We hope that this information empowers you, your loved ones, your family to consider psychiatric advanced directives. If you would like to watch our full webinar, please go to our website, Families for Depression Awareness. FamilyAware.org is the website, and go to our trainings page. We do have an archive recording of the fantastic webinar that we did on psychiatric advanced directives and planning for a crisis. We have already had our question and answer portion, so we're glad that we did that. Follow the bit.ly link on the screen or scan the QR code to fill out our survey. Your feedback really is important to us so that we can continue to bring wonderful programming to people living with a mood disorder and their loved ones. So from all of us at Families for Depression Awareness, thank you and have a good day.